Hello and welcome. My name is Howard Rowley. I'm from the University of Wisconsin in Madison, and today I'll be discussing epilepsy imaging state-of-the-art. I'd like to first thank our organizers and sponsors, the Bangladesh Society of Radiology and Imaging, as well as the Radiological Society of North America and their International Visiting Professorship Program. Today we'll take a clinical overview at the substrates that cause either new seizures or epilepsy, and we'll draw a distinction between those. We'll help to design imaging protocols based on clinical features and seizure type, and come to understand what particular entities such as mesial temporal sclerosis and cortical dysplasias are particularly linked to medically refractory epilepsy. These are my disclosures. I do have arrangements with a number of our corporate partners, and I'll be talking about some off-label uses of contrast. This is where I'm from. This is the middle of the United States. Wisconsin is here just above Chicago and near our beautiful Great Lakes. In Madison itself, we have a very large student community, about 45,000 students out of a population of only about 200,000. We have a beautiful lake called Lake Mendota just outside our student union, which is just across from our hospital and research center that you see here. We hope you'll come visit us someday. Now here's one approach to epilepsy imaging, and this is one I think that some of our emergency physician colleagues think about or don't think about, as it were. And this is an actual requisition, a patient with new seizures, and the reason for the exam that was given was to find something. So this sort of shotgun approach, just sort of blasting away with no particular idea in mind, I think limits our ability to properly design studies. So what we'd like to do is step back and look at what causes epilepsy and use that information to inform our protocol choices. So our outline here will be to look at a clinical overview of seizures and look at a structural imaging approach. And we'll divide it into pediatric versus adult cases, patients with new seizure today versus chronic recurrent seizures, which is the disease of epilepsy. We'll particularly look at MR protocols, although we can translate some of these thoughts into CT as well. And in the end, we have to recognize that epilepsy is not a structural problem. It might be caused by a structural problem, but we have to recognize the importance of functional imaging and direct evaluation of the electrical circuits in these cases, particularly the refractory epilepsy cases, to better understand what's actually causing epilepsy in this particular patient. And we'll come to that at the end. Now, let's look at a few definitions. What is a seizure? Well, it's a single event, and up to 10% of us may have a seizure during our lifetime and never recur. It's a cortical neuronal electrical discharge. So by definition, it comes from gray matter, not white matter, not from the cerebellum, not from the spinal cord. Now, epilepsy is simply the disease characterized by recurrent seizures. So there is a difference. Seizures, a potentially one-time event, pretty common, and from an imaging standpoint, fairly straightforward in most cases. Whereas epilepsy, particularly medically refractory epilepsy, is a chronic recurrent illness characterized by seizures. Now, this is very common everywhere in the world. In the U.S., about 2% of the population has epilepsy. Most of these patients are well controlled by oral medications, either single or in combination. But about 20% of patients remain medically intractable. They still have seizures despite best combinations, and so a large number of these patients exist in all countries. And they really bear the brunt of epilepsy morbidity and sometimes mortality. They have potential developmental delay if they're a child, social and occupational implications for everyone. They account for 75% of epilepsy cost. So we have that downside, but from an imaging standpoint, it's important to recognize even those with intractable epilepsy can be cured if we can find the epileptogenic zone, the area that's causing the seizure specifically at onset, and if that area can be localized and safely resected. So we have an important role here in helping to define substrates for cure in those hardest to treat patients. Now, in terms of classification, there are many schemes. I was actually a neurologist before I was a radiologist, and I still like the big picture scheme that you see here, which consists of generalized seizures or partial seizures. Generalized seizures or epilepsy are characterized by an immediate loss of consciousness, often major tonic-clonic generalized convulsions. They're also the most common form in children, where they're usually in the form of absence or petit mal type seizures. When we have primary generalized epilepsies without focal accompaniments, structural lesions are much less likely to be encountered on the imaging studies. We still look for them, but they're less likely. And in fact, some of these, like absence seizures, the subjects may, quote, outgrow them as they go into later years. Now, the other type, which is very important, is partial, and you can equate that with focal onset seizures. They may have auras, or they may have simple motor or simple sensory seizures. These seizures can become secondarily generalized and have major motor features. There are two flavors here. There are simple partial and complex partial seizures. With simple partial seizures, consciousness is preserved, whereas with complex partial seizures, consciousness is lost at least at some point. And things may arise, say, with an aura, with complete consciousness, going on to complex partial, going on to secondarily generalized seizures. But from the imaging standpoint, it's important, particularly if we have any focality, that we hear about that and go back and look twice at those areas for candidate structural lesions that could be leading to that type of focal seizure. So history is critical. It is everywhere, but even more so with epilepsy cases. We want to know how old the patient is. Obviously, do they have risk factors such as a known primary cancer or prior trauma, that sort of thing? Are these new onset seizures today in the emergency department, or is this a patient from our epilepsy clinic with chronic recurrent seizures, that is to say, epilepsy? Because although the list is going to overlap, there will be an important distinction when we come to protocoling. And of course, again, generalized seizures versus focal seizures, we have to be particularly on the job to find the substrates for focal seizures. We know there's something there somewhere. We just have to design the right protocol and try to find it. Now, we have a lot of options for imaging, obviously. Depending on the circumstance, we may start with CT, and that's perfectly adequate, particularly for new seizures in a large number of cases. But if we have the ability to obtain MR, and particularly when we have refractory epilepsy patients, we're going to go on to MRI and have a strong preference for that over CT. And furthermore, if we have it, we'll want to use high field systems like a 3T scanner, if possible, to get the best possible exams. Again, it really pays off. If we can find the substrate for their epilepsy, we may be able to offer them a cure. This is just one example of our screening brain protocol. This would be appropriate for anyone with any acute illness, acute seizure today. It's nothing fancy. We've got a 20-minute protocol that gives us pre- and post-contrast imaging of various sorts. Post-contrast, you'll see some of my cases. My first post-contrast series is a flare, in this case a volumetric flare. And that gives us the attributes of everything you've come to know and love about flare, but also gives us a T1 enhancement effect bleeding through into most parenchymal lesions. So we can scan once and recon many with this sort of volumetric approach. These sorts of sequences, depending on your vendor, might be something like Cube or Vista or Space, for example. Now, having spent 4 or 5 minutes getting that, my last post-contrast series is going to be a volumetric T1 of some sort. And examples might be things like SPGR or MP-RAGE or Bravo, depending on your vendor. Again, volumetric series, scan once, recon many, so that we have a great deal of information in a very short amount of time. And as you'll see when we divide things up into pediatric and adult populations, this is the sort of exam that can easily identify the substrate for new seizures in the vast majority of cases. Now, as we go through and look at epilepsy, we'll find that we should be spending more time and resources on these protocols for these patients. It wouldn't be appropriate, I think, to just have a seizure protocol for everyone, because you'd probably be doing too much for the new seizure patient and not enough for the chronic refractory epilepsy patient. At least you can fine-tune it and spend your resources getting extra imaging for those refractory epilepsy patients. So in particular, when we look at these patients, we want to add a volumetric, high-resolution T1 weighted sequence. We want to ideally look at this in multiple planes in real time. We want to interrogate the hippocampi, as we'll see later, preferably in an orthogonal plane to the long axis of the hippocampus. We want terrific gray-white distinction. We want excellent visualization of the cortical anatomy. So this means typically something like 1 millimeter slice thickness in a volume so that we can get these sorts of images. And we'll scroll through that looking at the cortex, the hippocampus, and the periventricular regions, each individually very carefully to pick out even the smallest possible lesion. So the T1 volume is key, often done with inversion recovery techniques. Now, we also want to include a couple of additional sequences, and we'll see why as we go through our cases today. We want some sort of T2 star or susceptibility weighted scan, and that's to pick up cases like this, which is a post-traumatic epilepsy case, or, for example, with cavernous malformations. If we don't include T2 star, we'll miss these lesions, and even the smallest one can be a cause for seizures. We also want to include direct coronal evaluation for evaluation of the hippocampus, typically with multiple tissue weightings, T1, T2, and FLAIR, so we can define the substrates of hippocampal sclerosis responsible for a large number of our medically refractory epilepsy patients. So to summarize, with acute seizures, we'll want a nice screening brain exam. CT may be adequate, MR is better. And for epilepsy cases, we'll want to go to MR, and we'll want volumetric T1s, T2 stars, and direct coronal evaluation, particularly for the hippocampus. And we'll see why that is as we go through the important causes of seizures by age. So let's look at the protocol design as driven by the known pathologies that are either most common or most important for the age groups. And we'll take a look at first new seizures in the pediatric population, and then we'll look at epilepsy in the pediatric population. Then we'll come back and look at new seizures in adults and refractory seizures in adults and children. So this is going to be our approach, and it's important to recognize if we're going to go out looking for these substrates, we should know what the common and important ones are. For new seizures in a child, things we don't want to miss: infection, trauma, venous infarction or tumor. In adults, it's going to overlap similar entities, but here as you look at older adults, it's things like tumors and infarction that are going to start creeping in. In a child with epilepsy, we're going to be thinking about phacomatoses, cortical dysplasias, cavernous malformations, and old injury of any cause. In adults, the list would include those same things, but also mesial temporal sclerosis, certain types of tumors, cavernous malformations again, and infections including but not limited to parasites. So let's take this somewhat arbitrary classification and put it to work. See if we have a patient who's either pediatric or adult with either a new seizure or epilepsy, how we can develop our protocol and look at some examples for each of these types of categories. So here's a child with new seizures, and this is one of the things I worry about and I don't want to miss. This is a patient with bacterial meningitis. We can appreciate at first glance on the diffusion weighted imaging, we have patchy areas of diffusion restriction corresponding to edema on the T2s, and there's extensive leptomeningeal enhancement on the post-contrast T1 as well as the post-contrast T2 flare. So this is a don't miss diagnosis. You can imagine that the leptomeningeal inflammatory response here to the meningitis can cause secondary ischemia. So don't stop with the non-contrast scan. Contrast really helps you see the direct signs of leptomeningeal inflammation and directs you toward the meningitis diagnosis. Also, in infants with new seizures, we want to be particularly mindful of the possibility of the unfortunate circumstance of non-accidental trauma or shaken baby syndrome. Here, a child at admission with multiple subdurals, also had retinal hemorrhages. There's some subtle right hemisphere edema on the CT that we can all appreciate, I think. And then at follow-up, we have diffusion restriction in the hemisphere. So these sorts of holohemispheric diffusion changes in combination with subdurals, highly suspicious for non-accidental trauma and a common cause of seizures in this setting. Another thing we need to be on the lookout for is venous ischemia. We sometimes forget to think about this, but it's particularly common in children, especially those with an intercurrent illness, dehydration, conditions like leukemia, as you see here, where they may have been having chemotherapy, nausea, vomiting, dehydration, and they're set up for venous sludging and thrombosis, particularly with some chemotherapeutic agents. So in this case, we can appreciate the empty delta sign on the CT, swollen hemisphere with a hemorrhagic venous infarction, and on MRI, a methemoglobin filling the superior sagittal sinus, corresponding to lack of flow on our phase contrast MRV. For some reason, even acutely, venous ischemia tends to cause more seizures acutely than arterial ischemia. As we'll see later, arterial ischemia in turn is more commonly associated with delayed onset seizures, often a year or more afterwards. And it may be that the blood products here are particularly irritating to the brain and trigger seizures. Now, most children who have brain tumors have their tumors in the posterior fossa, as you know. But there are supratentorial tumors, such as this ependymoma. This child came in from playing outside and told his mom that his hand was broken. He was having focal motor seizures related to this supratentorial ependymoma growing into his motor strip. And of course, we will encounter phacomatoses in childhood that can lead to early onset seizures. This is a fairly classic case of tuberous sclerosis in a 10-week-old now with seizures. We can see in this unmyelinated brain a number of abnormalities. We have some large brain stones, cortical tubers. We have these bright nodules along the subependymal region. You notice they're bright on T1 and they're dark on T2. So they're following the signal intensity of mature white matter. If these had been gray matter heterotopia, which we'll look at later, they would have followed gray matter signal intensity. So this is another clue. And these sort of radial lines you see going through the white matter in various locations are also characteristic of tuberous sclerosis. Here's another phacomatosis I'm sure you're familiar with, Sturgeweber syndrome, or leptotrigeminal angiomatosis. Here in this child we have a shrunken hemisphere, atrophic, with mineralization. You can see on the T2 and T2 star weighted images. We can appreciate that there's an extensive racemose angioma along the surface. The T2 flare shows that particularly well, also shown on the T1s. And if we look at perfusion, it's very sluggish flow on this first moment transit time map. So in Antmini, again, these patients will typically have a port wine nevus over the ipsilateral forehead and V1 distribution and contralateral seizures. And if you look carefully, these are often bilateral abnormalities as well in the brain. Now let's look at patterns of cortical malformation. This is adapted from work done by Jim Barkovich, and I'm grateful to him for teaching me a lot about the development of the cortex and how it informs how we should look at imaging studies. Now, in order to get a handle on this, we have to stop for a moment and just look at the embryology of cortical development. You may recall that the immature neurons develop and divide along the edge of the primitive ventricle. There's an interkinetic migration. Some neurons populate and develop. Others are being pruned back and dying. But eventually, a subset of the neurons that are developing in this germinal zone will decide it's time to leave the germinal zone, and they'll radiate out toward the developing cortex. And they follow these radial glial guide fibers, these purple fibers. You can see the neurons shimmying up the pole here to find their home in the developing cortex. And when they get to the cortex, they lay themselves down from outside in so that eventually we have a 6-layered cortex. There are separate neurons, for example, in the GABAergic family, that are radiating in a more tangential way across the layers of cortex and becoming organized in that fashion. So there are 3 principal features here: the proliferation of neurons, the migration out along radial glial guide fibers, and subsequent organization into the cortex and folding, and this happens between the first trimester and even postnatal life. You can imagine, as with any complex system, things can go wrong at any stage, and that helps inform where we should be looking on our imaging studies. For example, we may proliferate extra neurons and not die back. They may stay in the starting gates, if you will, and leave these subependymal nodular heterotopia of gray matter. And for some reason, they especially like this periatrial region. Or the neurons may get partway out, and maybe an adhesion molecule is defective, and they'll all arrest at the same point midway through their migration to the cortex. That might give us something like a band heterotopia you see here. As you go from the ventricle out, of course, you should see white matter and then gray matter. But here we've got white matter, gray matter, white matter, gray matter again. So there's a rind of extra neurons here in the middle of the mantle. Now, another thing that could happen is they might get all the way out, but then there might be a destructive or toxic process late first trimester, early second trimester, leading to disorganization of that organization phase. That leads to polymicrogyria. As you see here, this is a patient with schizencephaly, open lip schizencephalies bilaterally, and this lumpy, bumpy cortex at the inner surface is polymicrogyric cortex, and this is inherently epileptogenic. So knowing that embryology helps us gestalt, look at our imaging findings in a different light, and helps our search pattern to look for these sometimes subtle abnormalities. So here, for example, these periventricular nodular heterotopia, again, on my coronal plane, I always want to check the edge of the occipital horns. These seem to occur very commonly here. It's hard to see these if you're just looking at axial imaging. So we need to know where to look, and we have to specifically interrogate the edges of the ventricles for these sorts of nodular heterotopia. And it's easiest to do, at least in my experience, in that coronal plane. We may get masses of neurons that become arrested out in the cortical mantle, as you see in this case from Jim Barkovich. We may see double cortex. This is more images in the patient I showed you earlier with band heterotopia, and these can have a familial basis. So beyond helping this patient, you may help their family understanding specific mutations that they should be aware of for their own counseling. We can also have areas of thick cortex, pachygyria, lissencephaly. This is particularly prevalent posteriorly. It reminds you of a premature infant type cortex. It's not sulcated properly, and these patients often also have seizures. Now, this is an example of a patient with polymicrogyria. This was a patient from my practice who came in with status epilepticus, and despite best efforts, didn't make it. And we can appreciate at autopsy here this lumpy, bumpy, very busy appearance of the entire frontal lobe back to the sylvian fissure. These gyri are more normal, as you'd expect for a brain. And this area here corresponds to this smaller hemisphere and this irregular, what appears to be thickened cortex. But as you'll see, if we have adequate imaging, we'll see that this is an irregular gray-white junction characteristic of polymicrogyria, which was proven pathologically. Another feature that tells us this wasn't, for example, a destructive process like a porencephaly from an injury in utero, for example, is that we have a number of dysplastic veins over the surface of this cortex. And the development of the veins follows the development of the cortex. So when we have an unusual lesion, sometimes the dysplastic veins give us another clue that this is really a developmental abnormality. These are MR images in a baby who had cytomegalovirus, which is associated with polymicrogyria. And as you look at this case, you sort of decide that the more you look, the more you see. You may at first jump to these areas of jumbled, busy cortex with this nodular appearance at the gray-white junction, but the more you look, you realize almost all of the cortex in this patient is abnormally lumpy, bumpy. This is diffuse bilateral polymicrogyria in a small brain due to cytomegalovirus. This is that example of schizencephaly and polymicrogyria we saw earlier. And again, multiplanar imaging can help us see that irregular, bumpy appearance and not mistake this for something else. Now, with schizencephaly, we also are mindful to look for additional features like septo-optic dysplasia or de Mauzière syndrome. We see the septums missing here. And in other images, I'm not showing you the optic nerves were small in this child. Now, sometimes the abnormalities are not nearly as easily picked up. This is a patient with cortical dysplasia, and this cortical dysplasia is down at the depths of the superior frontal sulcus, and you can appreciate this sort of smudgy appearance at the bottom of the sulcus. Sometimes you'll see a funnel-shaped tail extending toward the ventricle, presumably along those radial glial guide fibers that were once there. And this is very subtle, but very important. This sort of cortical dysplasia can cause focal seizures, developmental delay, and the other side of the coin is if that's in a safe area to remove, we can treat these children surgically and prevent a developmental delay and allow them to achieve their milestones just as any other child. So subtle, yes, for sure, but very important to be able to pick up this sort of finding. You may be aided by additional information about frontal lobe seizures with, for example, Fencer's postures, or you may know that the EEG has frontal spikes and that'll help you, but this is a finding we should be able to make, this smudgy gray-white junction. Here's one that's a little easier to see. This is another cortical dysplasia, a balloon cell dysplasia, and it reminds us very much that there's a spectrum of cortical dysplasias, cortical tumors, and even gliomas that can also look very, very similar and will remain in the differential until we sort it out. I guess the good part of this is if this is in a child, for example, you're going to want this to come out if it's epileptogenic in and of itself from a dysplasia or if it's a tumor. And so earlier surgical intervention is called for in these cases. Now, in that particular case, we were concerned about tumor non-invasively. We can get spectroscopy. As you see here, this is a press box. So we've suppressed the water and then interrogated using a two-dimensional chemical shift approach. And this green box here has choline, creatine, and NAA in a normal amount. And so we don't have the elevated choline suggestive of a tumor. And this was good evidence that this was not a tumor. But again, whether it's a tumor or dysplasia, if it's symptomatic, it's going to come out by best recommendations. Now, sometimes we need additional imaging and functional approaches to defining the epileptogenic foci. We prospectively called this gyrus abnormal, believe it or not. It looked smudgy in this and other imaging in this patient with frontal lobe seizures. But just to be sure, in this case, the epileptologists and the functional neurosurgeons decided to implant an electrode array, platinum electrodes over the surface of the brain, subdural electrodes and subdural strands. We could then localize exactly where these were located at the time we were recording ictal events during a video EEG hospitalization. And then having co-localized this abnormality structurally to the electrical activities recorded during seizures, the surgeons and the epileptologists and the family and we were all more confident that this should come out, which it did, and was a proven cortical dysplasia, and this child has remained seizure-free. So those are some things we think about in pediatric populations. We'll next move to the adults where we'll have some of the same thoughts. The differential is going to be a little bit different, but certainly overlapping. But we'll have the same approach, where a patient with a new seizure probably just needs a decent screening brain exam, whereas a patient with medically refractory epilepsy should probably get a more detailed evaluation particularly should have MRI with volumetric T2 star and oblique coronal series. And that's because we want to hit the most common causes and the most important ones. So let's look at some examples, and this won't be any surprise to you. What are we thinking of when we see a patient in the emergency department with new seizures? Well, certainly acute infections like viral encephalitis. Here, the most commonly identified one, herpes simplex type 1, in a patient with new seizures with only a day or so of prodrome of confusion. Herpes simplex 1 virtually always involves the insular cortex, and we all remember it's supposed to involve the mesial temporal region. It does. We may have hemorrhage as this case. And remember, this is the limbic system, so if you look carefully, in addition to the temporal lobe, you'll often see cingulate gyrus involvement. And of course, these can be bilateral, and we want to spot this early so patients can be treated with antiviral agents promptly. Now, everywhere in the world, and I'm sure also in your country, we have parasites, and in particular, cysticercosis is an extremely common cause of new seizures and epilepsy. Cysticercosis was found in this graduate student who'd been traveling to Mexico, who was a UW-Madison student. And with new seizures, we conducted a screening MR, saw this slightly complex cystic lesion with a little guest inside and some surrounding vasogenic edema. On high-resolution Fiesta or KISS type imaging, we can actually see the scolex here. So an easy diagnosis to make. Now, a rarer condition, but an important one that can sometimes present with seizures or look like seizures, at least movement disorders and myoclonus, for example, and will have abnormal EEG, sometimes simulating seizure activity, is Jakob Kreutzfeld disease, a prion or proteinaceous infectious particle. We know now, of course, from Stanley Prusner's work that this is due to protein trafficking or malfolding of proteins in the brain. From an imaging standpoint, if you have a patient with some of those atypical features, of course, particularly if they have a rapidly progressive dementia, we want to include diffusion-weighted imaging and FLAIR. With diffusion, we can see bright signal in the striatum as well as ribbons of bright signal in the cortex. And this is one condition where a high B value, and especially higher diffusion weighting, if you will, brings out these changes quite well. Now, what about some commoner things that cause new seizures or epilepsy? This is a patient with post-traumatic epilepsy. Anytime we bang our brain or have a prior infection or a prior stroke or old trauma of any type, we have the potential for gliosis, and neurons can become injured and become a site for epileptogenesis. This is a patient who'd had frontal head trauma decades earlier and then showed up with new seizures. We can appreciate bifrontal encephalomalacia and spongiosis or gliosis. And then on our gradient echo, which we're always going to include for epilepsy, we can see signs of hemosiderosis, the smoking gun, that this was an old hemorrhagic bifrontal contusion. Now, if we're going to go after signs of prior head trauma, particularly in the context of either ongoing deficits or epilepsy, we want to do the right sequences. And that's going to be including diffusion, but also T2 star. We can appreciate in another patient here that we don't see a great deal on a fast spin echo or turbo spin echo T2. We can at least see in retrospect that there are some areas of edema, certainly. We see more on diffusion. This is an acute case actually, where we have areas of diffusion restriction in the callosum and out at the gray-white junction, the hallmark of diffuse axonal injury. Now, we can see this much better, of course, when we use either high field or T2 star weighted sequences or both. On a standard gradient echo T2 star, we can appreciate all these areas of signal dropout indicative of, in this case, acute deoxyhemoglobin, and later it would be developing hemosiderin. If in the same patient, the same moment, we get a susceptibility weighted sequence or SWAN, we'll see a magnification of this, much more sensitive for even the smallest areas of injury. So this can be important in defining the substrates of prior trauma. Now, in other cases, when we get to our middle-aged years, besides post-traumatic epilepsy, another very common cause is tumors, either primary brain tumors like glioblastoma or astrocytoma, or more commonly, metastatic disease. So from the imaging standpoint, middle-aged patient, new seizure, this is one of the rule-out diagnoses, and it's why contrast is included for our screening brain protocol in that setting. And what we're looking for is not hard to find, typically enhancing lesions like this metastatic focus to the superior frontal gyrus. We may also see older patients with new seizures. And if you tell me you have a 60 or 70-year-old with a new seizure over the telephone, I'll tell you the most likely cause would be an old arterial infarct. Not today infarct, something that occurred a year or even 2 years ago, like this old left MCA infarct, presumably because of gliosis. We can also see it occasionally in the subacute setting as a cause of new seizures. This was a 21-year-old who had a patent foramen ovale, as it turned out, and an embolic infarct to her right middle frontal region. When she was referred to our hospital, she was referred as a brain tumor, and we told them that this looked like gyral pattern of enhancement. It looked like an infarct. They didn't believe us and took her to surgery and biopsied, and now we know this is a biopsy-proven subacute infarction. So we need to stick to our guns, even though things may not be common in that age group. When we see characteristic changes like gyral patterns, we want to raise the possibility of ischemia. If there's any doubt, just wait a few weeks. The tumor will still be there, and the infarct will start to evolve and resolve as you'd expect. What about chronic epilepsy in the adult? Here's a patient. Again, I collect funny requisitions. Here's somebody who had nocturnal seizures for 170 years before they sought attention. I don't know how your patients are in Bangladesh. Ours are pretty stoic, but as a rule of thumb, I think if something's been going on for, say, 100 years or so, it's probably time to come see the doctor. So this is chronic epilepsy, and we'd all agree on that. And what are the things we need to think about in particular when we see a chronic refractory patient, medically refractory epilepsy? Well, the number one cause that's identified, at least in surgical series, so there's a bias there, but the number one cause is actually mesial temporal sclerosis. And this is rare in children. We've seen it as early as age 6 or 7, but it's pretty darn uncommon. It's usually somebody who's had 5, 10, 20 years of seizures, and typically of the temporal lobe variety with complex partial features. The pathogenesis is not precisely known. It may be post-infectious, may be from a cortical dual pathology with kindling of the hippocampus, may be due to febrile convulsions. I don't think anyone has really sorted this out. But the final common denominator is we end up with hippocampal atrophy and gliosis. In other words, a small shrunken hippocampus that's bright on T2, as you see here. This is a finding you won't see incidentally on imaging features for any reason, and so this is an important finding, and as you'll see, could be the key to cure of this patient's epilepsy, since if this it corresponds to the appropriate clinical setting and EEG findings, this imaging finding means that temporal lobe should come out, and it's likely to cure the patient. Now, before we get there, let's just step back for a moment and look at some of the anatomy of the temporal lobe. These are all coronal views of some type or another. The right ear is over here, the brainstem is down here, and as we look at the temporal lobe white matter stem, we see fairly regular appearance of the gyral anatomy. There's the superior temporal gyrus, the middle temporal gyrus, the inferior temporal gyrus, the fusiform or flat gyrus. We have the parahippocampal gyrus with the collateral sulcus here and the occipital temporal sulcus here. This, of course, is the hippocampus, the seahorse itself. On top of the hippocampus, we have this white matter band. It's called the alveus. Alveus means the belly. It's the belly of the seahorse. And this white matter band is actually the outflow pathway of the hippocampal neurons. It's flowing out from front to back it collects up in the fimbria or fringe of the fornix and then on up to the fornix. So on this diagram, we can appreciate the hippocampus. We have our alveus, and we have the outflow tract of the hippocampus feeding into the fornices and ultimately passing down then through the ventricles to terminate in the mammillary bodies. So it shouldn't be surprising to you that if we injure the hippocampus, say if we have mesial temporal sclerosis, we may have the occasion of dying back or Wallerian degeneration in the ipsilateral fornix and mammillary body. So on imaging studies, we want to be able to define this anatomy. We want to see that sort of interlocking C or U-shape appearance of the hippocampus that rolled up here, and we want to see nice symmetrical hippocampi and fornices. And that's because we want to be able to pick this out. A small shrunken hippocampus that's bright on T2, it's bright on T2 flare. It's particularly helpful when it keeps company with a small fornix on that side, the ipsilateral Wallerian degeneration. And this case points out why we really need the direct coronals. It's very, very hard to pick this out if you're looking at axial imaging. And so in a refractory epilepsy patient, a key thing is direct coronal imaging, typically with multiple tissue weightings T1, T2, and T2 flare, as you see here. Here's another case, in this instance, a right mesial temporal sclerosis case, also with right fornicial atrophy. Now, I want you to give this one a back of the room look. Look at these coronals and also at the axial, and you realize there's an asymmetry here. There is relative hyperintensity of the white matter stem of the ipsilateral temporal lobe. This right temporal lobe is brighter than the left. If you look at that white matter, look how nice and rich and dark this is. This is a little smudgy looking. And that may reflect recurrent seizures and lactic acidosis with sort of a low-level gliosis in the temporal lobe. In other cases, you'll actually see heterotopic gray matter here. But it's one of those ancillary features outside the hippocampus. Look at the amygdala, look at the white matter stem, look at the fornix, as a clue to lateralization for your temporal lobe epilepsy cases. So with that in mind, let's take a look at a case or two. Here's a patient who had medically refractory temporal lobe epilepsy. We got him in our new 3T scanner, and we're very proud of these images. We thought these looked pretty nice. And see if you see anything. We read this one as normal, but they had very clear-cut clinical semiology going for temporal lobe epilepsy. Here's just another look for you to see if you would be better than we were in this case. And so they went on to a more complete evaluation, not only with EEG, but prolonged video EEG in the hospital on a medication taper. And they also had intractable SPECT done. And we've merged this T2 to the FDG PET, I should have said. This is FDG PET, where in this color ramp, the bright yellow color is the high metabolism, and this red color is lower metabolism. So now let me just take you through this temporal lobe, and just look at this one. Look at this stripe appearance in that right temporal lobe. And so this is an important feature that we need to recognize short of getting the PET. This is a recognizable abnormality, and now when I show the same images to you, I think you can all appreciate that right temporal lobe at T2 brightness should have been a clue that there's something going on in the right hemisphere. And this is path-proven mesial temporal sclerosis. Now, how we review the studies is important. It's important to use narrow windows even on your flares, or especially on your flares. Here the hippocampus is normal. Here it's small and it's bright. And don't be confused if you use contrast like I do with my flares. This bright band above the hippocampus is simply normal, enhancing choroid plexus. Now we can do fancier things. We can measure the volume of hippocampus. A lot of groups have looked at this, and it's better than your eyeball. It does take specialized software, but it helps you further define and refine your evaluation. You can measure the T2 relaxometry, exactly how much T2 bright is this. There are packages available commercially now to look at volumes. These have been mostly developed, like this one, to look at patients with dementia, with Alzheimer's specifically, comparing to normative atlases. We're starting to see this used also for epilepsy. We have to remember that this is actually an important differential for mesial temporal sclerosis, that Alzheimer's patients also get hippocampal atrophy. Typically, they don't have visible bright signal on the T2 flare, even though they do have gliosis pathologically. But the key thing with Alzheimer's is we have marked ex vacuo dilatation of the temporal horn. And in fact, the ratio of the enlargement of the temporal horn to the smallness of the hippocampus is the most telling morphologic feature we'll see for Alzheimer's. So don't confuse this for mesial temporal sclerosis. We can also do advanced imaging like spectroscopy in the hippocampus. It's pretty hard to shim down in this area, but it can be done. And we can appreciate here a shim box over the hippocampus. What we'd be looking for here would be a dropout in N-acetyl aspartate, a marker of healthy neurons. We can also more precisely look at white matter with techniques like diffusion tensor imaging. So, for example, the white matter stem, we might be able to see some decrease in fractional anisotropy in an epilepsy case. But how much this is clinically useful, I'm not sure, to be honest with you. We're not using it clinically in our practice at this point. We are using DTI for a range of other mapping applications and for preoperative assessments, however. Now, let's say we found mesial temporal sclerosis. What can we do about it, and does it make a difference? It makes a huge difference. If you have concordant clinical features, EEG, and MRI, you can go to the operating room and do either an anterior temporal lobectomy or a selective amygdalohippocampectomy. And in that type of patient, they're more likely than not to be seizure-free, even if they've had seizures refractory for 20 years. So these sorts of surgeries can be really life-saving in these patients and can result in longer quality years of life as well as actual improved survival. So in the right patients, these sorts of epilepsy surgeries are key. We've also seen recent developments that are still sort of a work in progress, but here from John Willey at Emory, we can see another approach to dealing with mesial temporal sclerosis. This is MR-guided laser interstitial ablation, where patients are put directly in the MR scanner under stereotactic guidance. A probe is advanced, a laser probe, into the hippocampus, and then under direct MR evaluation, they can look at the heating at the tip of the probe and dial in exactly how much heat they want to put over what volume in that hippocampus and achieve a laser ablation of the hippocampus. So stay tuned. We don't know exactly how this will fit or whether it will fit, but we're seeing more and more of this in practices in the U.S. So let's summarize. Mesial temporal sclerosis, a very important entity that is the most commonly identified structural pathology in medically refractory epilepsy patients. Because of that, in refractory patients, we always want to get direct coronals, T1s, T2s, and T2 flares to look specifically at the hippocampus. We want to see a bright hippocampus that's small and it's lost its internal architecture because of gliosis. But just as important as these signs are things you shouldn't see. You should never see mass effect. You should never see enhancement. And so that would send you toward a different differential diagnosis, of course. So what are some of the other substrates we might encounter in refractory epilepsy patients? Here's a 20-year-old woman with more than 10 years of refractory temporal lobe epilepsy, yet she's found to have a tumor, a specific type of tumor, a dysembryoplastic neuroepithelial tumor, or DNET. These are really sort of what used to be called an oligoastrocytoma. They're a very benign tumor. They're surgically curable, and they have a characteristic sort of soap bubble like cystic-like cavity pattern, especially on T1s and T2s. So this is actually a good lesion to have. It's surgically curable and will also take care of these seizures. It can be either mesial temporal, as this case, or anywhere out in the cortex. Another entity you need to think about specifically with refractory epilepsy is the cavernous malformation, either single or multiple, as in this case. These have a typical popcorn bright appearance on T1s and T2s with a surrounding rim of hemosiderin. Pathologically, they have blood and calcium in them, and these may have a familial basis when they're multiple. You can also see the development of cavernous malformations, also known as cavernomas, in the drainage field of a developmental venous anomaly. DVAs are seen in about 4 or 5% of normals, and most of the time of no consequence. I try to hide this finding in the body of the report. But if I see one with a cavernoma or with gliosis around it on T2, I'm going to call it out because it may be that slow venous sludging over years can lead to the birth of a cavernous malformation. We've seen that happen pre-existing developmental venous anomaly, later on hemorrhage in the drainage field. And if you use 3T systems with susceptibility weighted sequences, you'll see small cavernomas in a large number of the DVAs. How we deal with this, we're not sure. Unless they're symptomatic, they're really a don't touch lesion. Now, another thing to think about with epilepsy is the imaging abnormality that I'm seeing right now actually the cause of the seizure, or is it the effect of seizure? Sort of the chicken or egg classic question. And we can see postictal edema patterns that are there no matter what caused the seizure to begin with. You can see it regionally in one hemisphere. I'll show you examples. Or you can see it bilaterally in the setting of posterior reversible encephalopathy syndrome, or PRES. Now, PRES, you may be aware of, is usually seen in patients who are not healthy patients. They're usually people on medications such as chemotherapy, anti-rejection medicines for transplant situations, or a patient with malignant hypertension or eclampsia. There's something at baseline that's different about them, and it may be priming their blood vessels in a chronic way, such that when they then have a seizure, they have essentially autoregulation breakthrough. It's characteristically in the posterior half of the brain and is a characteristically mostly vasogenic edema pattern. Now, I've said a lot. It's better to just look at the pictures, and I think you'll be able to gestalt this with me. Here is another child who is actually a shaken baby, and we can appreciate this postictal pattern where we have diffusion restriction out in the cortex acutely. If you looked in a day or two, it might march to subcortical. And you notice this is a non-vascular distribution. This is probably apoptotic cell death, programmed cell death, related to these prolonged seizures in this child. Here's an adult with prolonged focal seizures, left-sided body, right-sided edema, and slight diffusion restriction, as you see here. So you may encounter this, for example, in diabetics with epilepsia partialis continua. Patients whose diabetes is out of control may have focal seizures that are prolonged and may get this sort of postictal edema pattern that will go away after their seizures are under control. This is an example of PRES, as we just talked about, with characteristic predominantly parietal, but also occipital and other areas in some cases, vasogenic edema following seizures. And again, you'll want to go to the chart and sort out what is their predisposing feature, whether it's chemotherapy, anti-rejection medications, or the like. And we'll want to exclude venous ischemia since we have complicated looking bilateral lesions here, but this is going to go away as soon as the inciting underlying condition is taken care of. Now, we'll just finish up the last couple of minutes here, reminding ourselves that although we've looked at a lot of nice structural causes of epilepsy, in the end, epilepsy is a functional disturbance. It's not structural, and even if we find the most tantalizing structural lesion, that doesn't mean that lesion is causing this patient's epilepsy. So it's always going to come back to your neurologist, epileptologist, or neurosurgeon to put it together with the whole picture. Now, sometimes we can help put that picture together with other functional type imaging modalities. So let's look at some of those and glean what we can from a more comprehensive anatomic and functional look. Now, this was another patient. I didn't save the requisition, but it really said rule out seizures. Here's a functional CT exam. They had a seizure on the scanner, and this was one of those rare instances where I said, yes, this is seizures because I saw them, but I don't think that particularly helped them. So functional CT, not widely practiced. More commonly, we're going to turn to more advanced imaging. And in particular, we may look at either ictal SPECT if the patient's in the hospital and we can inject rapidly within seconds after a seizure. We'll see increased metabolism. Or more commonly, as this case shows, interictal PET, where we use fluorodeoxyglucose and look for areas of hypometabolism that may be then co-localized to structural lesions or subtle lesions we didn't see to begin with. So we can see this dark hole here, hypometabolism on interictal PET. Very, very helpful in terms of localization. What about functional MRI, which is, of course, based on deoxyhemoglobin, oxyhemoglobin shifts? Well, we certainly use this for mapping in epilepsy patients with or without lesions and look at memory sometimes, but because functional MRI is inherently limited by hemodynamic responses, whereas epilepsy is measured in milliseconds, it's inherently ill-posed to answer the question of where the epilepsy came from. Besides, we can't have patients sitting in our scanners for hours waiting for a seizure to occur. So practically speaking, a very good tool, but not specifically for the epileptic zone localization. Now, something that is very good is EEG, either scalp or implanted, or MEG, or magnetoencephalography. Now, MEG is a scarce tool, but quite good for some of these cases, particularly the lateral or neocortical epilepsies, where what we do here is we actually record extracranially the magnetic fields that are inherent. You remember the right-hand rule: every time you have an electrical discharge, you have a corresponding magnetic field. These are sometimes passed out through the scalp more easily, particularly for deep cortical epileptogenic lesions. And you can pick them up, these squids or superconducting quantum interference devices, and magnify them and then co-localize them to separately acquired MRI. So these squid arrays, typically now whole brain, will look at spikes and then use all the information in 3D to then map it back onto the patient's separately acquired MRI. So these are interictal spikes, for example, showing us that these areas of polymegalovirus are quite active in an interictal way and probably are the cause of the patient's seizures. Well, that's helpful, especially if there are multiple lesions, but sometimes it's even more helpful when things are discordant. Here we thought we had polymegalovirus in the temporal lobe, but when we looked at MEG, the spikes were all coming from the sylvian fissure. So structure does not equal function. We always need to put this together with the whole picture. So I hope this overview is helpful to you. I tried to highlight that with this field, we need to consider whether the patient has a new seizure today versus epilepsy. New seizures probably just require a good screening brain exam and not much more, while chronic refractory epilepsy patients should take the extra resources, extra sequences, including high-resolution volumetric imaging, T2 star, and direct coronal imaging. We're going after the most important and most common epileptogenic diseases by age groups, as we've gone through by example. And always remember, in the end, no matter what you find, it's got to be put together with all the clinical and electrical features before we can be sure that it's related in fact. So I hope this was a useful approach and you'll be able to use it in your practice. If you have cases you'd like to send me or suggestions, I would welcome that. I want to thank you for your attention. Thanks so much, and I hope you have a great rest of your conference.